Okay, welcome. Welcome all of you to this special event and special day, because today we will celebrate Sydney's inaugural lecture as professor, and as you probably all know, he will be the first professor, first chiropractor in the Netherlands who will become a professor, and we're obviously very happy and hopefully make it a beautiful day. At the end of the day, yes, we hopefully all go to the inaugural lecture of Sydney, but first we have this symposium. For me, it's also a special day because I think Sydney we met about 30 years ago, have been working together for a long time now, and actually Sydney was my first PhD student. So I'm especially proud today that we can celebrate this success. We have a program with great speakers. And the first couple of speakers, I will only introduce them and make sure that they don't talk too long, and we'll mainly have the task to check the time today. But after the first four presentations, we will have a panel discussion. So we don't have questions directly after each presentation, but after the first four, we have a panel discussion. So either remember your questions to the first, second, or third presenter, or write them down in your telephone, or if you have still a pen and paper, because otherwise you may not remember your questions to the first presenter. We will start with Tammy. Not only here because you have, let's say, a direct conflict of interest here as partner of Sydney. But you've been a chiropractor for 42 years, worked in practice, but you've also been involved in education of chiropractors nationally and internationally, postgraduate and continuing education. You also have been a founding member of the Stichting Chiropractie Nederland, which obviously, not sure when was that? A long time ago. But also that was obviously a memorable moment in the history of chiropractic in the Netherlands. And you've also been involved in various commissions in European bodies and other international bodies. So we're really happy that you're going to talk today about the topic of chiropractic care and actually what is chiropractic care and what are the risks associated with spinal manipulation, and looking forward to your presentation. The floor is yours.
Good afternoon. Hi. I thought I was going to be all very calm and no, I didn't. I thought I was going to be nervous, but I'm actually so excited because this is amazing. So, this afternoon, we're talking about cervical arterial dissection. This is on the occasion that a chiropractor becomes a professor in a prestigious university, and although chiropractic is not the mandate of his chair, he is one of the very few colleagues in the world where a chiropractor becomes a professor at an institution at which there is not a chiropractic education. So, let's go back to where it all began. Picture this. 2 chiropractic students looking for a way to make some money during their study take a job at a neurologist's office in Santa Ana, California in 1990. They have to go through hundreds of paper patient charts and identify cases in which a patient had a stroke following a chiropractic visit. The neurologist was Scott Haldeman, one of our featured speakers today, and this formed the beginning of a long-standing relationship between him and Sydney, resulting indirectly in today's subject. So cervical arterial dissection following a visit to the chiropractor or manual therapist. We have some colleague manual therapists present today. I might have just as easily entitled it Cervical Arterial Dissection Following a Visit to a General Practice of Medicine, because as we know from the study from Cote and Cassidy from 2008, the risk of vertebral stroke is equal amongst a visit to between a visit to a chiropractor and a visit to a general practitioner. They found that the increased risks of VBA stroke associated with chiropractic and primary care physicians is likely due to patients with headache and neck pain from VBA dissection seeking care before their stroke. I think this is called protopathic bias. Am I right? Okay, good. Okay. So, why the extraordinary interest in complications associated with spinal manipulation? It comes continually under fire. It is seen as violent, dangerous, and unnecessary. Somehow, however, it survives, having been around far longer than probably all current medical procedures in practice. Earliest records in Europe go back to 400 BC, and much of the writings were from the fathers of medicine. During the 1800s, however, it fell into disrepute as those propagating its use and teaching it were often also coupling this with religious-type philosophies and magnetism. At any rate, mainstream medicine did not pick up the practice, and by the last century, manipulation was practiced by the non-medical lay practitioner and was only in the last 50 years taken up by the field of physiotherapy and gradually made the shift towards mainstream. But the fact that it is not the exclusive domain of the medical profession, I think, has resulted in its disfavor and the consequent extraordinary interest in complications associated with its practice. If in fact it is as dangerous and useless as our critics say, why does its use persist? Well, you know, quackery, people can be easily persuaded into doing things, but I think it goes far further than that. If we stop practicing manipulation of the cervical spine because we say it's too dangerous, it doesn't show effectiveness, we're going to stop. It will continue to be practiced, but they're no longer in the hands of those who are being schooled in it, but by people who are lay practitioners, and the risk to the population, to general health, goes up exponentially. Recently, I saw a woman in the practice who said to me, she lived with headaches. She did not know what it was to be without. I treated her cautiously, without manipulation of the cervical spine, but when we finally took the step, and I say we because we took the decision together, she said, I feel like $1,000,000. Her face lit up, her headache was immediately gone, and all of you here have seen cases like this. The relief of pain took place only upon administration of high velocity, low amplitude, high cervical manipulation. I think that the numbers support us in this, that manipulation is clearly not intrinsically dangerous, but under certain circumstances can be the last straw in a chain of factors which can culminate in a disastrous result. 3 years ago, there was a court ruling in Holland where a chiropractor was found not responsible for causing a stroke, which followed immediately upon a cervical spinal manipulation. So the profession felt vindicated, felt relieved. Why were we exonerated? Because causality cannot be demonstrated. Randomized clinical trials cannot be carried out to demonstrate any such association. So this will never be a case of causality. However, just as with smoking, we know that smoking has never had a randomized controlled clinical trial carried out, but everyone accepts the association. Not to say that what we are doing is that dangerous, but that we mustn't assume that the only way of looking at this is through an RCT. So I think that the failure to demonstrate causality is not the same as there being no role played by the treatment modality. And as the number of cases continue to mount, and it will, we will continue to be placed under the magnifying glass regarding our role and responsibilities. So what can we do? We need to find ways to slow down the number of cases which are brought into association with manual care and so contribute to patient safety. But how? We are continually told that there are no tests which can predict this condition. We can, however, look for the risk for stroke in general. This is not difficult. We all understand how these patients look. And the most important factor is hypertension, and taking blood pressures and looking for people who are hypertensive will do them a service. Recognizing the stroke in progress, clearly important. And finally, can we identify those with risk factors for arterial dissection in general? Not specifically cervical, but arterial dissection in general. Just take a quick look at stroke so we know where we are. I have a thingy here. We understand that, does this show? No, never mind. 85% of all stroke is ischemic, 15% hemorrhagic, and of those with ischemic stroke, by far the most common are those who do not have a dissection. These are the people who are older with vascular risk factors like hypertension, hypercholesterolemia, and hyperlipidemia. These factors are not part of the profile of those undergoing a dissecting stroke. Around 2% of all ischemic stroke is caused by, as you see there, should be an arrow. Yeah, arterial dissection. This type of stroke is brought into association with manipulation and is known to be cervical arterial dissection, CAD. Arterial dissection occurs in the young. It is not something that is seen in the older patient. And it is the suggestion from the literature that this is part of a generalized vasculopathy. So why is it so that they are younger patients? If we look at the mechanism on stroke, non-dissecting versus arterial, we see on the left-hand side the non-dissecting stroke, which is caused by atherosclerotic plaques and the typical cardiovascular picture that we understand, resulting in interruption of blood flow to the brain. On the right-hand side, we see an example of an arterial dissection mechanism. This is a structural failure of an arterial wall, resulting in an intramural bleed, forming a hematoma which dissects the vessel wall. As this expands, this results in obstruction of blood flow, resulting in ischemia and infarction. If we take away from this, the mechanism can be further elaborated, but I'll leave it at that. The mechanism involved with dissection has a different pathological substrate than non-dissecting stroke. So we need to figure out how to identify them. Hypertension, we've mentioned, recognizing in progress. I'm going to go past this. Spotting a stroke. We know all the signs that we should be looking for. And in practice, we should be carrying out routinely when we want to treat the cervical spine, the 5D3NA, diplopia, dysarthria, dysphagia, dizziness, drop attacks, nausea, numbness, nystagmus, and ataxia. Oh, we are on the wrong slide. No, I've got to go back, excuse me. This is where I'm meant to be. I find in this group the first three not so challenging in identifying when they're abnormal. Dizziness is a very tricky one because people come into us for dizziness for all sorts of reasons, and we need to differentiate in ear amongst others. And this can also be seen in conjunction with nystagmus. We need to know more about how to interpret. Perhaps some of you here are really good at this. I'm not. I look for it in every patient, and I always think to myself, do I really know what I'm looking at? Do I know normal from abnormal? Some of it I do, some of it I don't. Ataxia, differentiating cerebellar ataxia from sensory ataxia, and numbness of the face. So, CAD can develop without there being any neurological deficits present at the time that you see it. It can take days or weeks before they're present. So obviously, doing the screening is not a blanket solution. And the most important clinical presentation which we need to be on the alert for is the severe headache or the headache as never before. And I learned this lesson from Dr. Haldeman. He said, watch out for this. Migraine is also one of the associated signs we need to be looking for. I, again, have gone... Okay. If there is no increased association between a visit to a chiropractor or manual therapist and the subsequent development of a stroke, what are we all doing here today? Why is this subject still of interest to us? Well, in those younger than 45, there are 3 times more likely that a visit to a chiropractor or a general practitioner preceded the stroke than in controls. This came out of Cassidy and Cote's study also. So if in fact there's just as much increased risk from both the GP and the chiropractor, it's not the manipulation that is at issue, it is the presentation of the patient. And what do we see? These are under 45 by and large. So the issue to me lies with the age group. What do we know about this age group? As age increases, mobility decreases. And the younger population being more mobile, perhaps there is a link between musculoskeletal and vascular mobility and arterial dissection. In the systematic review that many authors are present today for, and Wilco Jacobs is our next speaker, he will talk about, they found a moderate certainty of evidence for 2 risk factors, migraine and MTHFR-TT homozygosity. And something has gone wrong here. I want to go back. It made a huge jump. There we go. I bumped this thing. So, MTHFR-TT polymorph what? What are we talking about? One paper, recently published, 2024, starts to make the association between this polymorphism, which, by the way, is present in quite a large percentage of the population and is brought in association with all sorts of diseases, cardiovascular diseases, but many other systems are seen to be associated with this. However, finally, we're also seeing there's an association between this and the development of hypermobility spectrum disorder, or specifically Ehlers-Danlos syndrome. So perhaps we have a link between a genetic finding and something we can observe clinically. The spectrum of Ehlers-Danlos syndrome, while being an extreme disease and something we don't often see in the practice, I have seen it, but it's very rare. However, why I include this slide is to show you that joint hypermobility and arterial dissection are 2 features of Ehlers-Danlos, and arterial dissection is our issue today. Now here we see a CT angiography of a patient with vascular Ehlers-Danlos, in which 2 dissections are present and an aneurysm. I don't know the circumstances under which this was made, but it's really telling to say this is what people can be walking around with. So can we say, if there's a link between a genetic finding and a clinical observation, the systematic review is going to show us that there's some link possibly between cervical arterial dissection and this polymorphisms. And we know now that these polymorphisms, there's a suspicion that these polymorphisms are brought in association with hypermobility. We have then possibly indirect evidence of a link between hypermobility and cervical arterial dissection. So now we get into a clinical situation. Tissue laxity plays a role in the development of some forms of CAD. So this provides us with a clinical approach to tackle this subject. How do we look at joint laxity? Well, the first step is a primary screening tool, and you don't even have to formally administer this. This will come up if you just simply start checking a patient for hypermobility. This is our experience. You start with the checking on hypermobility, and they say, oh, when I was a child, I could put my leg behind my neck. Then you're starting to look at this, and you can quickly answer this. Also, kneecap or shoulder dislocations. And then we do the orthopedic exam of Baton's scoring. This is a 9-point scale in which you look at hyperextensibility of the knees, the elbows, and the thumb approximating the forearm, and being able to put the hands flat on the floor, and also the pink, the 5th digit. 5 out of 9 points in an adult is a sign of hypermobility. In a recent case in our practice, we saw a woman of 25 who was referred by her company doctor for headaches, neck pain, dizziness, and nausea. She had been under physiotherapy care, and following the last treatment at the physiotherapist, she said, hij heeft mijn nek gekraakt. He cracked my neck. And that night she was vomiting. Now, either she didn't report this to the neurologist or the doctors, I don't know, but it wasn't in any of the reports which I insisted be sent to us before we would see her. And so the fact that she vomited following a cervical manipulation was not in the reports. She's seeing a psychologist, she's seeing a rheumatologist, and so all of these people have seen her, but what they did not discover is that she can do this and this. And so she's extraordinarily hypermobile. She's at risk for cervical arterial dissection. So needless to say, we are not treating her neck. In conclusion, I may be way off the mark in making this association in front of the scientists here. But for me, over years of seeing patients, I've become increasingly aware of the prevalence of hypermobility in my patient population, and it has always been apparent to me that a person with a hypermobile spine did not warrant manipulation. This is a hard sell to people who are very happy to crack themselves. I try to wean them off of this habit, not only of doing it themselves, but also of not seeing colleague chiropractors or manual therapists too frequently. If the mechanism of effect from spinal manipulation is to increase mobility in joints, why would we apply it to joints not restricted in their motion? I realize I'm making a huge jump from the findings in the systematic review to recommending clinical examination for hypermobility, but what are we to do? Wait 20 years for the evidence, because that's how long it takes. For now, at any rate, we can be extra cautious with this constellation of signs and symptoms. So to summarize, the clinical identification of some persons at risk for CAD are younger, have migraines, which I did not go into today at all with you, and hypermobility. Thank you for giving me your time and attention today.
Thank you, Tammy, both for keeping right on time and also for your clear and challenging presentation. So we'll continue with Wilco. You were already introduced, Wilco. You're a senior consultant and epidemiologist and has ample expertise in clinical research, systematic reviews and meta-analysis especially. And since 2014, you've been working as an independent researcher, mainly working on clinical trials, meta-analysis and systematic reviews. I'm looking forward to your presentation about the systematic review. It's an update of a previous systematic review, if I'm right?
Yes,
yeah.
From 2005.
Okay. Thank you.
You will see that in a minute. Thank you for inviting me, Sydney. We've been working for 15 years now together. Since my time at Leiden University when I was not yet freelancing. So I have to first get my own presentation on your screen. So actually now...
Can I help them with the screen? Yeah, he's got it.
I got it. So actually now more for the boring part, the science, I would say, I hope. So we did this systematic review. First I have to find out how to proceed this. Advance. No. Oh, so now I have your problem, I guess.
I use the cursor of the,
Yes. Keep trying. So this was the original review in 2005, which I was not involved in, but it was published in Stroke, and so it was now already 2023, 4 maybe. So it was time for an update. So that's what we did. No, I have to go back and forth. So first something about the epidemiology. It's quite an underreported situation, disease, as you may know, because mainly dissection will go unnoticed, but only if you have a stroke you will probably be diagnosed, in most cases. Research tells us that it's about 9 in 100,000 per person years, and with stroke and through per 100,000. And between 0 and 13.5% of those dissections will experience a stroke within 4 weeks. So those numbers don't match up exactly, but there's from different research so different populations, so that might explain that. And dissection is leading cause of ischemic stroke. Within the stroke population, it's the major cause, except for the unknown, which is larger, but then we know that that's a mix of other causes. So what you have is you have risk factors for getting a cut with stroke, and there are risk factors for getting a stroke, and they might be different, might be different risk factors, but there's also maybe a joint sort of risk factors that apply to both diseases. So I'm treating this as different diseases at the moment. So most research was done with comparing the dissection cases with or without stroke, and comparing them with stroke control groups. So what you get is you compare the risk factors in one population with the risk factors you find in another population. So you are actually analyzing the relative risk factor of getting these diseases within these two groups. So if the risk factor for getting a non-cut stroke is very high, and risk factor for getting a dissection is lower, it might end up as a preventive risk factor. You might miss real risk factors. It's not a real valid answer. So what you, in our opinion, what you need to do is use a general population, healthy patients, healthy persons, and assess the risk factors for getting a dissection in that population. That's the population that you want to say something about. So, for example, this paper did that, identified medical records of more than 100 million patients, and you get all the characteristics of those patients, and you see which one get a dissection and which one don't. So what we did, we pre-registered our review in Prospero. We did a search, extensive search in Medline, Web of Science, and Embase. We did a screening of the papers by two persons independently, and then we had a consensus meeting about the final inclusions. We screened that screening we did in Covidence, which is an online tool for doing systematic reviews screening. We extracted the data into a big Excel sheet, which quite exploded because of the many studies and many risk factors. The meta-analysis, if we could do any meta-analysis, we did in R, which you see a small sample of the code on the bottom right. The risk of bias was done with Robbins E, which was quite extensive and problematic to assess, and took quite some time to fill in. And the problem is that it sets the observational studies at a low risk, and then you have to you have to hope that it can get upgraded. But it's hard to get a good high level of evidence that way, using the GRADE approach. What type of studies did we include? Because there are no randomized trials, of course, in this because it's etiological research. We looked for case control studies. Actually, what would be best would be cohort studies, big cohort studies, population based, but they're not. We did not expect those to be largely available, so we also included case crossover studies because we knew about the study of Cassidy. We wanted to include that. subjects with a confirmed or assumed diagnosis of dissection. Not all studies present their MRI diagnostic data, but we included any mention of dissection. So any risk factors, there were many in the studies, but we did not exclude any in advance. And the outcome was occurrence of a dissection, cervical arterial dissection, either vertebral or carotid or basilar. Full reports in the English language. So in the end, we ended up including 128 studies. 54 of those used healthy control groups, and some used both different control groups, which is interesting. And those 54 studies included 484 estimates of 130 different risk factors. So you can imagine that in average you have 4 estimates per risk factor, so that's not a lot. Some had more, some had less. So many risk factors had only one estimate because it's some were very specialized tortuosity that way, or very obscure risk factors, which might be important, but we only have one estimate for those. So basically, this is a very busy slide, but this is basically the main results. I kind of highlighted the interesting things. I am glad that you explained what this is. The heterogeneity, because that all the kind of genetic factors ended up quite high in all these studies, with odds ratios of over 2, which we defined as high risk. Also migraine, indeed, which you also mentioned. Minor trauma with a low level of evidence, also a high odds ratio. But minor trauma was kind of defined very heterogeneously in all the studies. Some only mentioned minor trauma, or it was like a accident, something. It could be different things. Hypertension was the one that was mostly assessed, and indeed showed an increased odds ratio, not very high, but a quite specific small confidence interval. So that also led to not very low, somewhat increased level of evidence. So that was the main. So those that were like not very low, I give you the forest plots. As you can see, on the left for the MTHFR heterogeneity, for migraine and for minor mechanical trauma. And these my favorite for hypertension, because there's a lot of studies and it shows that it's quite heterogeneous, the effects, but mostly are indeed in the risk side. Some have overlap, but actually only one was below 1. And what you can also see is that so this estimate 1858 is for the general population risk factor, and for studies that use stroke as a control group, the odds ratio was actually like preventive, which doesn't make much sense, but that's what you learn if you use the stroke control groups as a control group, which I think does not help us much in understanding the risk factor for dissection. Limitations, of course. We were dependent on case control study designs. The diagnosis of the section, because it's usually it gets diagnosed once it becomes symptomatic, and then often you have a stroke, I guess. I'm not an expert, but that's what I learned. And many of these studies, because Tammy also mentioned this is a study for the young and under 45 years old, but many of these studies that were explicitly like searching for risk factors for dissection also include like older people, but also very old people. One study made a stratification below and above 65 years old, so they were actually also looking for very old people and the risk factor for dissection in that age group. So I guess I don't know. I guess it also occurs at older age, or their population was different. They diagnosed. I don't know. And yeah, one of our what we thought ourselves was a limitation from the GRADE method is that it places observational at lower level of evidence. Maybe we were too strict. I don't know. But we just followed the methods, and that was a pity. Maybe it just can't tell us. Observational studies cannot tell us really, with very much evidence, what the risk factors are. What I think maybe we should, what should be best is have large registries, because it's like you're actually looking for, if you're looking at manipulative therapy, you're looking at more like complications of your treatment, and in pharmaceutics or in medical devices, there are large registries looking for complications in their treatments, and that could also be a solution to finding the real risk for this type of complication, which it actually is. So, because my title was on the program was, we would be looking at manipulative therapy as well. We found 4 studies. The cSMT studies from Engelter, Kozlov, Whedon, and Cassidy are well known. Because this is different from all the other risk factors that were assessed, that were like demographic characteristics or health status characteristics. This is an intervention, which is different, and it's an intervention for similar complaints. What do I mean with that? I don't know. But there are a lot of different control groups used in the studies that assess this. CADAS was a multi-center study. They confirmed the MRI, the detection with MRI. They only defined the risk factor manipulative therapy as CMT, cervical manipulative therapy, without further information. They use healthy controls and non-dissecting stroke. They found indeed an odds ratio of 3.6. That was for the compared to the healthy controls, which you may say that's a large risk, so it's a dangerous intervention. But as Tammy also mentioned, there might be the case of the protopathic bias. People are searching, looking for treatment for some certain complaints. So they're more at risk also because they have complaints and they have some underlying disease already, which might lead to dissection, and not the intervention that is performed to treat that symptom. So other studies used control exposures, primary care physician controls visits. for Koslov 2 years later. They defined the exposure as chiropractor visits in certain times before the dissection, and they used a healthy insured control group. So they also, when they did that, they found lower odds ratios, and because the odds ratio was, they included like the 1, so there was no risk. But for the primary care physician visits, the risk of dissection was actually increased. And Cassidy, they had a case crossover design. They used primary care provider visit also as control, and they found also the odds ratio is 3.14, but then also includes the 1 as a zero effect. The effect from primary care physician visit was also increased. Whedon, finally, they had claims databases. They defined the SMT with CPT, I don't know them, but they are like treatment codes, and ICD codes combination for headache and that sort of symptoms. They used 3 sorts of control groups: healthy insured, ischemic stroke, and case crossover control, so patients are their own control. And they used evaluation and management as control exposure. And they found very low odds ratios compared to the evaluation and management exposure, which I find rather hard to interpret. But their statement is that it's so you have not an increased risk from SMT exposure compared to as evaluation and management only. So these 4 studies, these 3 studies, last 3 studies, they included control exposures. It's trying to find like a comparable population in which to assess the risk for dissection, which makes sense in my opinion, because it's an intervention risk factor. Each of these studies included no larger risk from CSM than from that control exposure. And what we already mentioned, there may be caused what is known as protopathtic bias. My critic in that in these studies would be that the intervention is not well defined, because they use like fake descriptions and like CMT, chiropractor visits. I guess I'm not a chiropractor or manipulative therapist, but I guess that you do different things, that there can be different treatments and all kind of things, that some things are not related to having a risk, or it might be some movements or some interventions, some things that you do, and would be much better to look at specific things and not the chiropractor, would be my advice in future research. This was supported by the NCMIC. So, thank you.
Thank you, Wilco. And again, remember your questions if you have any to Wilco, and it's actually nice that there was a link, as you already showed, Tammy, between the results of the review and the relevance to clinical practice. So that's a nice example. We will now continue with Wendy Scholte-Peters. She's actually a colleague of mine here at VU Amsterdam. She's professor of working mechanisms and management of musculoskeletal physiotherapy. And she leads the musculoskeletal physiotherapy research here in Amsterdam, and also as a national musculoskeletal research network. And Wendy, you're going to inform us about the IFOMT framework for cervical vascular risks. The floor is yours.
Thank you. Hopefully you can hear me, yes. So first of all, thank you for inviting me, Sydney. Thank you for inviting me on this important day for you. And today I would like to tell you about the reliability and validity of the IFOMT framework to assess the consequences of a vascular disorder. And I do not have any disclosure, so most of my research is funded by these institutions. And as you all know, I think neck pain and headache are the two most treated conditions by physiotherapists, chiropractors, and manual therapists. And manipulative therapy integrated into a multimodal treatment has small to moderate effect sizes. But headache and neck pain are also the most two common conditions underlying a vascular pathology. So that's really important to realize. So the IFOMT framework aimed to deliver effective and safe treatments. And therefore, they started to develop an international framework aimed to support clinicians, so chiropractors, manual therapists, to identify vascular pathology to provide effective and safe care. But before diving deeper into the IFOMT framework, I would like to make a distinction between side effects and serious adverse events or complications. And side effects are other effects than planned when the treatment was provided. So you should think about, for example, an increase of symptoms or dizziness or irritation or stiffness or increase of headache. And most of those symptoms do often occur, so in 23 till 80% side effects occur. But in 70%, all of those side effects recover within 24 hours. So I hope that it will continue. Yeah, I will try to use the keyboard. Yes. And complications or serious adverse events on the other hand are changes in structure or function which lead to specific health disorders. And that can also lead to people that have to seek medical care or can even lead to the death. And vascular complications are the most common and most frequently reported complications following manipulative therapy, in about 58%, followed by more neurological complications, such as radiculopathy or myelopathy, or a combination of vascular complications or neurological complications or other types of complications, such as, for example, a fracture. And of all those vascular complications, a dissection is the most common vascular complication, followed by dissection with stroke. And a recent systematic review showed that serious adverse events most often occurred after a cervical manipulation, followed by massage and exercise therapy or even mobilizations. So if we look at the incidence of manipulation, then we see that there's a huge variation which is reported about this one complication after 20,000 manipulations, and it even varies to 1 till 6 million manipulations. And this huge variation can be explained by, for example, different patient populations, different types of designs, and different statistical methods to estimate the incidence. So an important question is, how can we as clinicians identify and distinguish headache or neck pain originating from a vascular origin from a more musculoskeletal origin? So we have to realize that some symptoms, or some people at some point in time will, with headache and neck pain, will look at the vascular pathology, but it can mimic a more musculoskeletal condition. So we really should know, so what are other factors that can explain people having headache or neck pain originating from a vascular pathology for a more musculoskeletal pathology. And headache and neck pain are the most common symptoms of people with a vascular origin. And the non-ischemic symptoms, such as, for example, dizziness or difficulties in swallowing or imbalance, this often occur later in time, and this time can vary from a few minutes to even a few weeks. So some important signs and symptoms, which already were mentioned by Tammy, that we have to be alert on during the screening are, so it's often a headache, an acute headache. So it's often acute headache with a real sudden onset of headache or neck pain. And that headache intensity is quite huge. So it's a moderate to high intensity, and the headache is classified as it's a headache unlike any other. So people didn't experience that type of headache intensity before. And often it's unilateral, and it's the first episodes of people having that headache or neck pain. And as also mentioned before, it's often in people having a younger age, or those having also additional pulsing tinnitus. And what we see, if the dissection will develop later in time, the non-ischemic symptoms or the ischemic symptoms will occur. And the risk factors which are related to a dissection are also mentioned in the presentation before. So we have to think about, for example, a minor trauma, or people with a recent infection, or those having a history of migraine, or specific genes, or people having a connective tissue disorders. All these type of risk factors can be related to an underlying vascular pathology. And originally, the iPhone framework was developed for people providing manipulative therapy and exercise. But currently, there is a discussion within physiotherapy that we think that all clinicians, all physiotherapists, not only people who are delivering manipulative therapy, but also GPs and all physiotherapists should be aware of a vascular genetic contribution. And all those clinicians need to treat and refer patients accordingly. So they need to be able to make a distinction whether those headache or neck pain will originally be from a more vascular disorder or musculoskeletal disorder. And although the iPhone framework is currently widely adopted in clinical practice and also in all educational programs, we still didn't know what the reproducibility and the diagnostic accuracy of that framework was. And therefore, we started a research project within our group, and which aimed to assess the agreement, reliability, and diagnostic accuracy of the iPhone framework. And therefore, we measured 96 people having headache or neck pain, which are visiting a musculoskeletal physiotherapist, and 17 manual therapists estimated the risk of a vascular complication following manipulative therapy or exercises derived from the estimated risk of a vascular pathology. And they estimated the risk into 3 categories. So a high risk, which means we have to avoid treatment. So there could be an intermediate risk, so please also be careful, avoid treatment. And there could be a low risk for vascular complications, so that those people could be treated safely by manual therapy. And what we saw is that the overall agreement of those manipulative therapies in estimating the risk of vascular complications following manipulative therapy or exercises was 71%. and the overall reliability was fair. And as you can see on this slide, so the highest agreement, the highest specific agreement was for the low-risk category. And when we lumped the high-risk and the low-risk category together, and say, okay, high-risk and intermediate risk, they both mean, so you should avoid treatment. So we said, okay, there was no, at that time, there's no indication for manipulative therapy. So when we lumped those high and intermediate risk categories together, we saw that the overall agreement increased till 81%. So that means that we said before that there should be at least a 75% agreement to be acceptable. So at that time, the agreement became acceptable. And for the diagnostic accuracy, we included 19 manipulative therapists, which a mean age of 98 years. So most of those manual therapists were males, with a median experience in manual therapy of at least 7 years. And all of those manipulative therapists, they received an intensive training course. So there was 1 day of training in which they learned about risk factors for dissection and non-dissection, signs and symptoms for dissection and non-dissection, and they really learned how to use that iPhone framework to improve their clinical reasoning. And we assessed 150 people having headache or neck pain, which were seeking physiotherapy or manipulative therapy care. And those 19 manual therapists estimated the risk of vascular complications following manipulative therapy or exercises based on the estimated risk of vascular pathology into those 3 categories. And our reference test consisted of a consensus medical diagnosis of 3 different professions, so a vascular neurologist, an interventional neurologist, and a neuroradiologist. They both independently scored the estimated risk of a vascular complication following manipulative therapy. And they based their decision on important risk factors that they, from their profession, thought that would be important, so based on risk factors, based on signs and symptoms, and they also received a magnetic angiogram, so they had some visualizations to identify whether there was, for example, a pre-existing dissection or a stenosis. And when there was some disconsensus between those people, a consensus meeting was scheduled so that finally all independent people agreed on the reference test. And the reference test was performed blinded from the index test. And all results show that, or reference tests show that in 55% of the cases there was no indication for manipulative therapy. And from the index test, we showed that the results showed that 44% showed there was no indication for manipulative therapy or exercise. And our expert panel mainly based their decision on the clinical signs and symptoms that were available in combination with the magnetic resonance angiograms which were available. And the manual therapists based their decision on the clinical information, and they predominantly used the patient interview to reach their decision. So they said, okay, the physical tests were less important for us. So mainly the patient interview was the most important part for them. And the results showed that the sensitivity of that screening framework was low, it was 50%, but also the specificity was relatively low, it was moderate 63%. And also the diagnostic accuracy of the screening's iPhone framework was low. So the area under the curve was 57%, which means that in about 57% we can just correctly identify a patient having a higher risk of vascular pathology. And unfortunately, that is not much better than random guessing. Yeah. So our study showed indeed that there was the prevalence of people having no indication for manipulative therapy in our study was relatively high. So that could probably mean that we had some selection bias, and probably a lot of people in our group were expected to have a vascular pathology, and therefore they would like to participate in our study because they received an additional magnetic resonance angiogram, and they also received an additional consensus of other disciplines. So it could be that we had some selection bias. But I think it's also important that you really realize that our outcome was the risk of a complication, and that not all cases really received the complication. It was an estimate of a risk of complications derived from the risk of a vascular pathology. And we had to conclude that the current framework, as it is developed now, is unfortunately not able to guide manipulative therapists or chiropractors in their clinical reasoning. So probably that can be due to the quality of the framework, but probably it can also be due to a lack of training, although we all manual therapists in our study received an intensive training of about 1 day, but probably still they were not able to apply it correctly. But we have to conclude that the clinical use is currently still uncertain. And a recent qualitative Think Aloud study of another group, they aim to assess whether the outcome framework really supports manipulative therapists in clinical reasoning. So they invited 8 postgraduate students, and all those 8 students received 2 case reports, and they were asked whether and how that framework supported their clinical reasoning. And what that qualitative study showed is that in postgraduate students, this framework indeed supported their clinical reasoning, and especially related to a more vasculogenic hypothesis testing, and also the importance of the patient interview and the physical tests. But it's unclear how that framework supports clinical reasoning in more undergraduate students and also in clinicians. So that brings me to the end of this presentation, and I would like to thank my group. So without those people, it wouldn't be possible to have to show this Go for Safe group. So thank you for listening, and also Sydney, thank you for your invitation.
Thank you, Wendy, for your presentation, and maybe later we can discuss what the future of the iPhone framework then will be. The next speaker and the last speaker before the panel discussion is Dr. Haldeman. He's a neurologist and chiropractor and professor at the University of California and the Southern California University of Health Sciences. He's also founder and president of World Spine Care and has served as president of major spine organizations and also chaired the influential Bone and Joint Decade Task Force on neck pain. So he's a global authority on spine care and has significantly shaped global spine care policy and research. So we're very happy that you're here today and very interesting to hear your presentation. Thank you.
Let's figure out how to get this.
You probably get some help from the technician.
Where's the mouse?
There's no mouse here, but there's the technician who will help you.
There was a mouse here.
And better not to use this one, is my experience after.
This one is yours, right? This one? Yep.
And
Thank you.
And I assume that you can use
that works.
these to go forward and backward.
Thank you so much. Before I start talking about 40 to 60 years of my life and research in 20 minutes, I want to first of all thank and congratulate Sydney for bringing it here and for all the things. I've known him, as you said, for years. Came in as a student, new graduate. He then became an award-winning researcher, and now is currently endowed chair. Couldn't happen to a nicer guy. But I have known Tammy even longer. Met her a few years before I met Sydney. And I am also fortunate to be married to somebody who is smarter than me, more caring than I am, a better clinician than I am, who has set a stage that allowed me to achieve a great deal. And I know this is exactly, Sydney would say exactly the same with Tammy. Thank you so much for allowing us, Joan and Tammy, for doing what we've done. Okay, I graduated chiropractor in 1964. It was a great time. Never ever heard of a complication or a side effect from manipulation or from anything else. As a matter of fact, every patient I saw for 10 years as a chiropractor got better. Didn't matter what they came in with. They all told me they felt better afterwards. As a matter of fact, one patient, Dominic Kurtze in South Africa, old patient, my father, came in. I gave him a treatment. I was a kid. I was just out of chiropractic school. He went away, came in 2 days later and said, I broke out in this rash. My whole body was such a rash. And he said, that was the best treatment I've ever received. My body has never responded this way again. And in fact, many patients came and felt sore afterwards and said, this is what I expected of treatment. Every time I take a medicine, I get sicker afterwards. So I expect when somebody's treating my back and neck to feel a little soreness. It means something's happening to me. And it was very common. Never heard of a harm or a side effect at any time during my chiropractic career. I also, at the time I graduated, the AMA Committee on Quackery published its results saying they want to contain and eliminate the practice of chiropractic from the world. This book said that it will result in the decline of chiropractic, encourage ethical complaints whenever possible, encourage chiropractic unity, and oppose inroads into research, actually oppose research into chiropractic, and oppose inroads into the hospital. As a matter of fact, the chairman of this committee said rabid dogs and chiropractors fit in about the same category. And this spread throughout the world. Then I was asked to be part of the National Institute of Neurological Disease and Stroke, NINE's guidelines on spinal manipulation. Conclusion of this is there's little scientific data of significance in which to evaluate the approach. There was no science. There was no science that the critics could put up and say there was anything wrong with it. There was no science that the advocates could put up and say that they could justify what they were doing. So then I went into neurology, and I became a neurologist. I became actually pretty good, did a fellowship in electrodiagnosis, thought I was a pretty good neurologist. No patient ever got better no patient ever came to me saying they were better as a result of my practice as a neurologist. That was the one thing I missed when I moved from chiropractic to neurology. My mentors, one of my mentors, Professor Stanley Van der Noort, who was head of our department of neurology, became dean of medicine, had an interesting philosophy. He was the authority on multiple sclerosis in Southern California, recognized throughout the country. And I spent a lot of time with him, and he basically was giving his multiple sclerosis patients the anti-cancer medicines, the anti-inflammatory medicines. He had these concoctions of medicines that had never been tried, all of which were very serious poisons. And he basically told me that in the absence of evidence, it was expected the doctors would use their best judgment in order to help patients. And that was the expectation of their patients. I then moved to the Veterans Administration Hospital, where I did a fellowship in electrodiagnosis and neurourology. And the world authority on neurourology, Bill Bradley, was my mentor there. And we started stimulating with electrical stimulation the pudendal nerve in women and men. We began sticking needles into the guts. We were blowing up the bladder with cystometry. And then he got this bright idea, why don't we blow up the bowel with air as well and measure pressure changes? Never had any IRB. We never even told the patient what we were doing. That was the standard of care at that time. I then went and became eventually on ISSL's, International Lumbar Spine Society, and became president of NAS. And Alf Nachensen was probably my best mentor in that setting. And Alf would continuously say at every meeting, there is no scientific basis for anything we do for back or neck pain. He was adamant that there was no justification for surgery, there was no justification for injections, there was no justification for manipulation, there was no justification for anything anywhere else done, and in 80% of patients, we didn't even know what was wrong with them, what was causing their problem. So this is a setting you have to recognize if you want to start talking about complications. This all changed in '87 with the AMA antitrust trial, which forced the AMA to change its medical ethics so that medical doctors are now free to choose patients they served and the environment they served in. I was fortunate, I wasn't fortunate. I was asked to testify in this, and it nearly got me kicked out of my residency. So I get in private practice, and all of a sudden, I'm being consulted, only neurologist in the country, probably in the world at that time, who also had some chiropractic background. So all these malpractice cases came in. The basic rule of thumb in the legal community, if something negative had happened after a chiropractic treatment, no matter how long ago, maybe up to a year later, it warranted a malpractice suit. And it was considered malpractice until proven otherwise. So all of a sudden, I had all these cases coming in. I made a lot of money from it as an expert witness. A real conflict of interest. But I didn't mind at the time. And then this student comes in, called Sidney Rubenstein, and says, I want to do research with you. So I hand him a bunch of these files, and he comes up, and we looked, and we said some people had seen a chiropractor, been treated for a while, and afterwards had gone to a medical doctor who found a compression fracture, and he said that was due to the chiropractic adjustment. And we had others who came in, had a chiropractic adjustment, and at some point afterwards had cardiac syndrome, and they said, that's the chiropractic adjustment. And we had others who came in and said, we had all this pain and aggravation. They went to somebody else, and they said, that'll serve you right for seeing a chiropractor. All of a sudden, I had to become an expert in vertebral artery dissection. So I searched the medical literature and found that there are total, in all the literature, 368 cases. The largest case series was 10 patients at that time. And but 1/3 of those were following manipulation. So that didn't look good at the time. So another graduate student came in, Frank Kohlberg, a chiropractic student. Frank Kohlberg came and wanted to do his master's degree. So we put him down and gave him all these malpractice cases, these stroke cases. And we had 53 cases. Then we published that in 60 cases. Ended up having over 100 cases. We tripled the number of post-manipulation strokes reported in the medical literature. Most of them were young. Most occurred within a week, some with 12 months afterwards. Well, all of a sudden, the medical community took and started warning of chiropractic peril. Neurologists were worried about stroke everywhere. The frequency of association is estimated by neurologists in California 27 a year, in Canada 21 a year. In Canada, another said 1 in 5,000 patients who see a chiropractor will stroke. And that was published in the national press. So what we looked at, the medical and some of the large published reports from people who do manipulation. And Robert Main from France said 1 in several million manipulations, it can happen. Cyriac said 1 in 10 million. Jasoviak said 1 in 15 million. Gutmann in Germany said 2 to 3. I think it was Germany, maybe in Switzerland. Said 2 or 3 in a million. It was a marked discrepancy between what neurologists were saying and what practitioners of manipulation were saying. So how did we look at that? I managed to get access to all malpractice cases in Canada from the malpractice company. And it was a requirement of a chiropractor, if a stroke occurred, if they even were aware of it or even thought about a stroke, to report that to the malpractice company. And in a 10-year period, they had 23 cases. And those 23 cases, it was interesting, had been consulted by over 219 medical doctors and 69 neurologists. So the average number of neurologists seen for each case was between 3 and 4. And that did not include grand rounds, because every case that ever happened got presented to the entire department, or published, or presented at meetings. But what became clear from this is that there are 10 times more chiropractors than there were neurologists in the country at that time. The likelihood of a chiropractor seeing a stroke case was 1 in 48 practice lifetimes. And there's only one chiropractor in 48 will actually have a stroke occur in their office following spinal manipulation. However, a neurologist can honestly say they've seen personally 3 to 4 strokes following manipulation, or they've heard of or been part of a discussion of 10 to 15 such stroke cases. So there was this marked discrepancy of referral bias, which was evident and explained some of the adamant opinions people had about it, either for or against. Started changing with the Rothwell study. I'm not going to debate the study. It was in case control, the first major case control study in Canada. And he noted a 5-fold increase in the incidence of stroke after who had greater than 3 chiropractic visits in the past month. But this was based in the entire province. It's looked at the entire provincial record on 9 patients over a period of 6 years. And the risk of his estimates of the risk of association was 1.3 vertebral basal artery strokes per 100,000 patients under 45 years of old. And that became a problem because Shivink, who is the real authority on VBAs, said this was the incidence in the general population. It was no greater than the incidence in the general population. Now, these are different populations. You can't directly compare them. But they are, in those days, at least something that made one look at it. So I had now to convince neurologists that maybe we should look into this further. Eric Hurwitz, a graduate student in epidemiology, was had gotten a grant from the NIH to do a randomized controlled trial on cervical manipulation, and it was blocked by the neurology department as an unethical study and a dangerous study. I was asked then to testify, to do the course at the American Academy of Neurology on vertebral artery dissections, and I did other presentations at NASS. I was able to convince the neurologists on Eric's study with the following. Luckily, at the time he wanted to do the study, the Quebec Task Force on Whiplash-Associated Disorder had been covered out, just been published. And they said that manual therapy and NSAIDs provided short-term relief. There were other studies from Bronfort and from the RAND Corporation, from Aker study in the BMJ, which said that mobilization and manipulation is probably more effective than muscle relaxants and usual medical care. And there was no proven value to virtually everything else. So I could present this data and say, look, you cannot allow millions of manipulations going forward in the country every day without at least allowing a study to find out whether it was worth anything. At the same time, we looked at the risk factors from our studies, and migraine, hypertension, everything else, all these classics. Again, we didn't have case control studies, we didn't have any direct, but if you compared what was published from our case series to the general population, nothing stood out as saying, this is something I should study. The other thing that is happening is that we're seeing all these papers come out with genetic predisposition. Recurrent dissections, we published one, but there were many others. The one we published was one was Sydney. And we found that recurrent dissections were very common. And trauma was not a significant factor in recurrent dissections. Then multi-vessel involvement was also very common, especially in the spontaneous group. And then there were a number of structural alterations and other things which were being found in these patients. The other thing, risk factor, which was becoming evident was that the case control studies for infection showed increase, became something to worry about. And that eventually led to the systemic work that Sydney led 20 years ago, which showed weak evidence for a number of risk factors, no real reliable method of screening patients, and likely a multifactorial component to the etiology of strokes. Then came the Neck Pain Task Force, which I chaired, and again, we talked about the stroke, but we started changing our thinking. And the thinking now on difficult manipulation was not complications, was not serious things, it was relative benefits and harms. If I've got a series of treatments, which should I try first, second, or third? And the green light is worth considering, likely helpful, is some evidence of benefit, and with minor harms. Yellow is, it might be worse, it might be helpful, there's some benefits not confirmed, but likely there, and no serious harms. And the third is not worth considering, where there are no obvious benefits or there are serious harms potential. So it's another way of looking at choosing a treatment approach. At the same time, we looked at the harms of NSAIDs. From the first day of use, all NSAIDs increased GI, bleeding, myocardial infarction, and stroke from one study, and this is the rest of the data on that. The opioid condition came up. 17% of all opioid prescriptions were being given for neck pain in the United States. And we all know the complications of that. And then we looked at surgery, elective surgery, in 10,000 cases in California. 6.7% reported complications, unplanned surgery in about 3 in 1,000, and death in 1 in 1,000. Unfortunate. The association does not appear to be real with manipulation. Association is real, but the causation issue has been addressed now by prior speakers. I have one paper which we have just submitted for publication with Jim Whedon. I've been working with Jim for a while. And we looked at patients who had seen a chiropractor, had received primary care only, and primary care with a prescription drug. And any adverse outcome was 14% lower if you went to a chiropractor, given these three options. Adverse drug events were 59% lower if you saw a chiropractor. Gastrointestinal bleeder were 9% lower if you saw a chiropractor than just seeing a family physician, or almost 25% higher if the primary treating physician gave a prescription. And renal failure was 22% lower if you had seen a chiropractor up front. It appears from this issue, this is for neck pain. If you saw a person and your first contact for neck pain. It has weaknesses. This is not the best study in the world, but it is at least an indication of where this thing goes. So in conclusion, my feeling is the current status of safety of spinal manipulation, as much evidence for benefit as any other intervention for non-specific neck pain, very high level of patient satisfaction and compliance. It's included in most, but not all, evidence-based guidelines for neck pain, sometimes combined with exercise, often referred to as manual therapy. Minor harms limited usually to reversible musculoskeletal soreness, similar to that of exercise. The rates are not much worse than going and telling somebody to go exercise. Serious harms are much less frequent compared to NSAIDs or other pharmaceuticals or invasive procedures. And it's probably not a risk factor for vertebral artery dissection, but strokes do occur following consultation by practitioner of manipulation or with any other practitioner who consults a patient with neck pain. I have two caveats. Wilco discovered this article, which I had not seen before. It was published just 2 years ago, which showed that 80% of all dissections that can be found on X-ray imaging are non-symptomatic. What the hang do we do with that number of asymptomatic dissections? What do we treat them? I don't know what we do. Probably put them on some kind of anticoagulant, but that's more dangerous than probably leaving it alone. This was found in a study where there was a 1,300 time increase in the number of cervical artery arteriograms which were done, and an estimate of 2.5% of all emergency room patients had a cervical angiogram. Is it worth doing this? That's expensive. The other study is interesting and follows what the iPhone people are looking at. There's two studies that just came out late last year from Australia, which looked at sudden acute neck pain, unusual familiar pain, and neurologic features with two different things. And these were only looking at patients presenting in the emergency room at a major hospital. And they found a fairly high level of cutoff for dissection if you presented with certain combinations of these. Has to be looked at better, but this is, I think, the direction it's going. So finally, my last slide, I decided to find out if I'm correct. So I asked ChatGPT. I asked ChatGPT for one sentence on the safety of cervical manipulation. And it told me that cervical spinal manipulation therapy is generally safe when performed by trained professionals, but rare adverse events, including arterial dissection and stroke, have been reported, highlighting the importance of appropriate patient selection and clinical screening. I thought that was a pretty good statement, and I decided I'm pretty smart after all. Thank you very much.
Thank you, Dr. Haldeman. It was nice to see such a long and impressive career in spinal care. I think Sydney and we stepped in the 90s, and I remember Alf Nakhamson, and the good thing about him was that he was a spinal surgeon, so he could speak up to the surgeons and his colleagues, and they listened to him. So hopefully you will also listen to the chiropractic researchers like Sydney, because that's one part of the game of research as well. It does not always lead to the expected results, but also if the results are maybe not the ones that you had expected or liked, take them seriously and think what you can do with it. But that's for the future. We now have 20 minutes time for questions to the first presenters. So I would like to ask the presenters to step forward. We do have a mic, so if you have any, or actually we have two, so one for the presenters and one then for the people in the room. Who actually has a question to one of the speakers? You do? Oh. Anyone? Yeah. Hopefully this works. Yeah.
This question is to Professor Haldeman or also Professor Scholten. What would you advise national associations to advise their members about informed consent and how to go about that?
I think we all have to do informed consent, but I wouldn't even put stroke on the informed consent because I don't think it's a complication of it. You're not at higher risk to get a stroke, but at the same time, I would add a sentence saying, strokes have been known to occur in patients who have a sudden onset of severe neck pain plus neurological symptoms. If you find this, let me know immediately.
Mm-hmm.
There's a lot of discussion about, indeed, informed consent also within the manual therapy. And the IFOAM framework recommends, indeed, to sign informed consent, but it also depends on the country itself. So in manual therapy, we now have advised that the written signed informed consent is not necessary anymore. So people need to be informed that the treatment, what would the probably effective treatment would be, what kind of side effects or complications can happen. And if the patients then together shared decision making, they agree on the treatment, and at that time treatment can be delivered. So written informed consent is not required at this moment here in the Netherlands for manual therapists.
You don't sue people very often in North America, in Europe. We sue people all the time.
No, that's true, we don't. Actually, the question that I had was that if you think, for example, about medication, you have all these lists of, long lists of potential side effects. And what probably happens is that if people read them, either they don't take the drugs because the side effects might be serious, or they take them and they will get any of these side effects. How do you deal with that as a chiropractor?
We administer, is this working? Yeah. We administer informed consent on all our patients. And it's quite remarkable. I can count on one hand the number of patients who've said no, or they don't want to. One person, she said, I'm not signing this. My husband's a lawyer. I know I don't have to sign it. She said, this is just protecting you. And she's right. And that is a problem I have with the informed consent. It's only actually about protecting the practitioner. Supposedly it's informing them, but what I see them do is read it very quickly. Sometimes they don't even read it. They start signing it. And I say to them, did you read this? Oh, yeah, it's fine. It's all good. And then if I think I've got a patient that I'm going to really need to do some work on the neck that I think is extraordinary, then I will take them through the steps. And I do tell them about stroke, but then I start explaining ischemic stroke. And at that point, I've lost them. So.
Tammy, did you treat the patient who didn't sign the informed consent?
No, if they won't, if they won't sign, I won't treat the neck.
Yeah, okay.
But we can sometimes agree to do mobilizations. Which is interesting because mobilization is just as likely to cause a complication if you're already having a dissection at that moment. There's no difference between dissection or activate or manipulation. But I make the decision not to manipulate.
But you did treat?
Yeah.
Okay.
Hi, I have a question for Wilco. Thank you very much for a very elaborate overview, but I was wondering, and actually in all the presentations, because many of the risk factors seem to be presented as univariable risk factors, like risk factors on their own. And you've, I think, gone through hundreds of studies. Didn't you come across any kind of multivariable real risk models, like, because, you know, one can be maybe not so much, but having and the lower age and hypermobility and your abbreviation that I forgot again, you know, it all may add up or even multiply the risk. So do you have any information on that, or can you elaborate on that a bit more?
Yeah, we did not include, we did not look at models, prediction models or things like that. What we did do is we include, when studies sometimes they present like univariate results or they have a multivariate analysis. And when multivariate analysis was available, then we took the multivariate estimate. So sometimes we have a univariate and other times multivariate. But indeed, that would be another question. How do these things combine? And do you get a better risk schedule if you have all these factors? And can you add some of those? Are they maybe strengthening each other? It could be. Yeah, we did not look at it.
But I think in clinical practice that is important because for clinical practice you want to have the best estimate for an individual. And having the best estimate of risk for an individual, you need multivariate models, I think.
Yeah, I think we totally agree with that. So in our group, we are indeed creating a prediction model for the high risk of complications following manipulative therapy. So we're working on that at the moment.
Question here?
One of the main problems with that is that almost all these are large database controlled clinical trials. So you do not have the option to pick what you're going to study. You've got to pick what somebody else studied in that database. And you have to deal with databases that have over 1 million people in it, or really you're not going to come up with anything. And there are no databases specifically for this particular issue.
For Wilco, a question. You had a very long list of all the risk factors, and you said the ones scoring over 2 are probably interesting to look at. But then the score for manual therapy on the neck was the only one below 1. So would that be a preventative factor then for CAD? Because that's the only one which scored very low.
Yeah, good spot. Yeah, so that's probably because of the control groups they used, they used the evaluation and management or primary care physician exposure as a control group, and compared to that was often a reduced risk. So yeah, that's why.
We didn't put it in the article.
Not yet. And the list was much longer from what I showed.
Hi, I'm interested in the opinion of the 4 speakers regarding the fact that if you look at the research regarding risks of SMT, you could wonder, or it's very strange, that why is it still such an issue? And Tammy gave her opinion, and she argued that maybe it's the fact that manipulation is not only used by the medical profession, but what is your opinion on this? Why is it still so relevant?
I think we should hear from someone else.
It's a holdover from the original AMA Council on Quackery, which, a whole generation has to die off before that's going to reverse. Like any political action. It's also a fact that chiropractors in many parts of the world are not fully licensed. You're lucky here to have a university-based place. There's always some conflict between physiotherapists and chiropractors out there in the big world, competitiveness, and other practitioners of manipulation. So a unity position on spinal manipulation is often not accepted or not widely available. And then we still have some weird chiropractors out there who make claims that cannot be justified, and which every time that happens, somebody's eyes glaze over. So there's a whole series of things that have to happen, but they're all happening. They're all gradually. The physiotherapy chiropractic conflict is breaking down. We're seeing in multiple centers they're working together very closely with no difficulty. We're seeing more and more chiropractic institutions are being educational institutions are at major universities, sometimes in conjunction with medical students at the same time. And we're seeing a general acceptance. And the other thing is this huge cost in disability for musculoskeletal and particularly neck and back pain. And that huge cost to society. Society's starting to look at that and saying, what are their options? What can we do? So I think it's moving in the right direction. It's still early.
Yeah, Tammy mentioned smoking as a risk factor. I think it took 65 years to get that into the public opinion that smoking is bad for your health. Who had a...
I have a question for, well, maybe one of you can answer it, but you talk about CAD. Should we separate CAD into vertebral artery dissections and internal carotid artery dissections for spinal manipulative therapy?
I have an opinion on that. Clinically, how can we? The patient in front of us, I can't possibly know what he has. I'm just happy if I can identify that he's at risk for dissection. So I think that the risk for arterial dissection in general is far more important than knowing which artery. I mean, even if someone who is at risk for aortic arch dissection because of an underlying vasculopathy, he's at risk for a cervical artery dissection from either one of these, for what I know.
The main reasons for vertebral artery dissection is more prominent in this discussion is that it presents with neck pain and headache. Carotid artery dissection, if it presents in pain, is anterior pain. It's not the same way. And therefore does not drive people towards a chiropractor. So people who develop neck pain, headaches, if they're inclined, chiropractic is one of their main options. If you come in with symptoms of carotid artery dissection, you're rarely going to go as a patient or be referred by a family physician to a chiropractor.
And probably what we should understand, I think, is the current hypothesis is that especially serious adverse events occur when a dissection is not recognized or probably even misdiagnosed. So we really have to try to distinguish people having neck pain or headache originating from a more musculoskeletal disorder or a underlying vascular pathology. And from what artery that dissection probably will come, I think that's really hard. And only, for example, the type of pain or the location of pain can help you to distinguish that somewhat. But I think if we succeed in recognizing that people having headache or neck pain will come from a vascular pathology, I think then we could be really happy for that. So I think at that time we can probably prevent serious adverse event, because what we think is that those complications especially occur when people are having an underlying vascular pathology, are treated with exercise or manipulative therapy or whatever. At that time, the pathology will increase and a vascular complication will occur.
Can I ask one more question? Or can I?
You want to ask a question as well? Yeah, so then, sorry, we go to you first.
What does the Dutch medical inspection ask to us manual therapists or chiropractors? Because the iPhone framework is not very good at sensitivity or specificity. What do they ask at us when a patient goes to court? Dus de juridische aansprakelijkheid. Wat moeten wij doen? Zit de Nederlandse inspectie op dezelfde lijn als de verenigingen? Of hebben zij een heel ander beeld?
I can probably only tell you something about what we within the manual therapy are asked for. So within manual therapy, we have developed a beroepsnorm, and that professional norm that's based on the content of the iPhone framework. And Dutch manual therapists need to follow that professional norm to treat patients and screen patients effectively. So that's what they ask for us.
Okay, thank you. Or do you
Just
want
want
to
to
add
mention
something?
that the Nederlandse Chiropractoren Associatie, we also have a beroepsnorm for cervical manipulation, which we should all be acquainted with.
Okay, then because of time, I would like to thank the speakers and also the audience for the questions. And risk is actually an important and interesting topic. And I was thinking about one of the things you mentioned, that maybe then if patients consider high risk, they may not drive to the chiropractor, which may be a good decision because the risk of getting an accident or dying when driving is far much higher than going to a chiropractor. But that's right. So the next and last speaker is Richard Brown. He's Secretary General of the World Federation of Chiropractic and spine clinician within the NHS. He has 35 years of experience and served as an expert witness and advised on chiropractic safety and ethics for the UK's General Chiropractic Council. And we're happy that you are here now to tell us something about the World Federation of Chiropractic's Global Patient Safety Initiative.
Thanks, Marts. Thank you. Okay. I think we're there. Well, I think daunting is the word that comes to mind this afternoon. Coming at the end of an afternoon of such illustrious speakers and quite formidable questioners from the audience, I'm glad I wasn't on that panel. So, have we still got the clicker, Moritz, or is that, did you hide it? Just use this? Okay. Right, so 12th of August, 1985, Japan Airlines Flight 123 took off from Tokyo, bound for Osaka. Just 12 minutes into the flight, a faulty repair to the rear pressure bulkhead carried out years earlier failed catastrophically. The resulting decompression destroyed all hydraulic systems, leaving the crew with almost no control. For 32 agonizing minutes, the pilots fought to keep the aircraft stable, but ultimately it crashed into Mount Osutaka. Of the 524 people on board, 520 lost their lives. It remains the deadliest single aircraft accident in history. It was a tragedy that was born not just out of technical failure, but out of a breakdown in safety culture, communication, and oversight. Now, Japan Airlines responded not with silence, but with transformation. So on the 24th of April, 2006, 19 years ago, on this very day, Japan Airlines opened the Safety Promotion Center at Haneda Airport. Not just as a memorial, but as a living, breathing commitment to learning. It holds pieces of wreckage, cockpit voice recordings, and even personal belongings from the crash. Every employee at Japan Airlines is encouraged to visit. The goal is simple: to remember, to reflect, and never forget the cause of complacency. And today, April the 24th, 2025, marks 19 years to the day since that centre opened. And the impact was felt on January the 2nd of last year, when a Japan Airlines A350 collided with a Coast Guard plane at Haneda Airport. The aircraft caught fire. But thanks to training, preparation, and deeply embedded safety protocols, all 379 passengers and crew survived, evacuated in under 20 minutes. That moment wasn't luck. It was the result of a culture built deliberately and sustained over decades. So as we reflect on patient safety today, we're reminded that true safety is not passive. It's practiced. It's remembered. And when it's done right, it saves lives. Now, it's a genuine honor to be here at Vrije University today, a university that not only produces outstanding research, but does so with a deep commitment to public value and global responsibility. And it's especially meaningful to speak ahead of the professorial inauguration of Professor Sidney Rubinstein, a friend, collaborator, and a leader in the advancement of research relevant to chiropractic worldwide. Sidney's work is foundational to much of what I'll be discussing today. Now, as the co-author of the 2024 Chiropractic and Manual Therapies paper, the World Federation of Chiropractic Global Patient Safety Task Force, A Call to Action. And I'm delighted that other authors of that, as well as Sidney and myself, are here today, and Katie Pullman's here as well, and it's wonderful to have her with us today. I'm excited to share the insights from our global initiative, why it matters now more than ever, and how we can promote safer chiropractic care everywhere from Amsterdam to Accra, from Sao Paulo to Sydney. Patient safety is not a luxury of advanced health systems. It is a fundamental right. The World Health Organization estimates that in low and middle income countries, 1 in 10 patients is harmed during healthcare, often due to system level limitations, workforce shortages, or lack of regulation. This leads to millions of lives lost and billions in economic losses annually. But patient safety in chiropractic is often discussed only in high-income contexts, where regulation is mature, education is standardized, and research infrastructure is generally strong. So our work with the WFC's Global Patient Safety Initiative aims to change that. We want to elevate safety in chiropractic as a global concern across all contexts, including under-resourced environments where chiropractors may be working without formal systems of oversight or support. The WFC Global Patient Safety Initiative, which was established in 2023, is an intentional mix of professionals from across continents, practice models, and stages of development. I was privileged to co-author this founding paper alongside Professor Sidney Rubinstein, Katie Pullman, and a diverse group of colleagues. So the initiative is driven by 6 core objectives: awareness and education about patient safety in every region, international sharing of best practices, analysis of harm, including underreported or poorly understood events, training strategies tailored to contexts, system-level monitoring, and ongoing accountability and evaluation. Critically, this initiative is not Western-centric. We do not assume that every chiropractor has access to electronic records, or a multidisciplinary team, or advanced imaging. Our ambition is to empower practitioners everywhere to identify risk and deliver safe, ethical care with the resources available to them. Chiropractic is practiced in over 100 countries, and its global footprint is growing. But that growth comes with complexity. In high-income countries, chiropractors may be integrated into insurance-based systems or national health services. In low and middle-income countries, however, chiropractors may operate independently without formal licensure or clear referral pathways. And in some countries, patients may access spinal manipulation from untrained providers, further complicating the landscape. But we must acknowledge this diversity of practice environments and avoid exporting safety frameworks that are unrealistic or irrelevant in low-resource contexts. Instead, we must co-create culturally appropriate solutions with local stakeholders, solutions that reflect on-the-ground realities, while upholding shared principles of professionalism, ethics, and patient protection. Now, at the heart of our initiative is the prevention of adverse events, but with a twist. We argue that safety must be about more than just what goes wrong during treatment. Much of the public scrutiny towards chiropractic focuses on errors of commission, doing something harmful, such as inappropriate spinal manipulation that leads to injury. These are real, serious, and they're important to address. But equally important, especially in under-resourced settings, are errors of omission. Not obtaining an appropriate case history, not performing a neurological exam, not recognizing red flags, not referring a patient with serious symptoms. These omissions can be serious and systemic, not due to negligence, but due to a lack of infrastructure, education, or support. And yet they can cause just as much harm. Our paper highlights this as a critical blind spot in the way we currently talk about safety. We must move away from viewing safety solely through the lens of individual failure. It's tempting to assign blame when a patient is harmed, but in reality, most adverse events are the result of multiple breakdowns across a system. And this is especially true in low and middle income countries where access to imaging, diagnostic, or even patient records may be limited. A chiropractor may be doing their best in a fragmented health system, and yet a patient may still experience harm. This isn't just a clinical issue. It's a policy, education, and equity issue. If we want to improve safety globally, we must also improve access to the tools that make safety possible, from referral networks to continuing education to basic equipment to professional regulation. So to guide our WFC approach, we aligned our initiative with the WHO Global Patient Safety Action Plan 2021 to 2030, which identifies 7 key strategic objectives: policies to eliminate avoidable harm, high reliability systems, even in resource-constrained settings, safety of clinical processes, particularly in diverse cultures, patient and family engagement, health worker education, skills and safety, information, research and risk management, and finally synergy, partnership and solidarity. Now, chiropractic's contribution to these objectives is growing. In some regions, chiropractors are already helping to fill gaps in musculoskeletal care. In others, they represent new or emerging profession, with opportunities to shape practice from the ground up, with safety as a starting point, not as an afterthought. Safety begins in education. But what that education looks like may vary dramatically depending on context. In high-resource environments, students may train in simulation labs, just like we see here at the Canadian Memorial Chiropractic College, with interdisciplinary faculty. In low and middle-income countries, chiropractic education may take place in modular programs or in private institutions or at hybrid learning formats, sometimes without formal accreditation. What matters is not uniformity, but competency. We must define the minimum safety competencies that all chiropractors, regardless of geography, should possess. And this includes red flag recognition, communication of risk, cultural competence, ethical triage and referral decisions. And in doing so, we have to listen to the educators, regulators, and clinicians in countries, including low and middle income countries, not just transferring models, but adapting them together. If adverse events aren't being reported, they aren't being learned from. And if they aren't being learned from, we're not improving. So one major challenge across the chiropractic profession and healthcare in general is the lack of safe structured systems for incident reporting. Fear of legal consequences, lack of institutional support, or absence of peer networks may silence reporting altogether. But safety improvement requires more than data. It requires trust. Practitioners must feel that their honesty will be met not with blame, but with support and shared learning. So that's why we're advocating for context-sensitive learning systems, including community-based care discussions, regional safety forums, low-tech or mobile-based reporting tools, or anonymous reporting options. The solution doesn't have to be high-tech. It has to be available, trusted, and used. And finally, we must elevate and invest in research relevant to chiropractors, especially as the profession expands globally. Currently, most of the data guiding safety practices comes from high-income countries with well-established health systems, regulatory structures, and academic infrastructure. However, the fastest growth in chiropractic is now seen in the low and middle income countries, regions where systems are still being built and where the realities of practice are often very different from those reflected in the literature. To support safe and effective care in these contexts, we need locally led, context-specific research designed by and for the communities and the professionals that it aims to serve. And this includes, but it's not limited to, the following areas. Common adverse events in local contexts. What type of patient harm are most likely in different practice environments? We all hear about the social determinants of health, and I think we can't ignore that in our discussions around patient safety. Do the patterns that we see in high-income countries apply elsewhere? We need real-world data on adverse events, near misses, and system-level vulnerabilities in varied global settings. We need access to training and mentorship. In many regions, chiropractors work in relative isolation, often without access to continuing professional development, specialist consultation, or formal mentorship. Research can help map where those gaps exist and identify innovative, scalable models for ongoing clinical education and supervision. Interprofessional referral behavior and collaboration. Patient safety often depends on timely and appropriate referrals. Research is needed to understand how chiropractors engage with other professionals, what barriers exist, and what improves collaboration in diverse settings. Culturally grounded patient expectations and communications. Chiropractic care is delivered within cultural, linguistic, and societal frameworks. What patients expect, how they perceive risk, and how they respond to safety disclosures can vary widely. And Scott and I have both seen that working with World Spine Care in underserved communities. So understanding these nuances is critical to ensuring informed consent, adherence, and trust. Infrastructure and regulatory influences on safety also apply. Safety outcomes are not just about individual clinician behavior. They're shaped by the presence or absence of infrastructure, regulation, record keeping, insurance systems, and legal protection. And research should really explore how governance models and regulatory systems support or hinder safe care delivery. And models for safety monitoring and learning in resource-limited settings. We need to explore how to implement lightweight, culturally sensitive mechanisms for learning from harms without imposing unworkable burdens on practitioners. This kind of research must be community engaged, culturally respectful, and solution-oriented. It must value practitioner wisdom, patient voice, and interdisciplinary collaboration. And most importantly, it must be resourced with support from international organizations, academic institutions, and professional bodies alike. And by investing in this kind of evidence, we're not only improving chiropractic safety, we are strengthening the profession's global relevance, legitimacy, and the ability to meet the needs of diverse populations around the world. And we need to recognize that global leadership on safety does not reside solely in the global north. It emerges wherever chiropractors, patients, educators, and systems work together to build something better. This is the spirit that I see reflected in the work of Professor Sidney Rubinstein, who's long championed applied, accessible research that addresses real-world clinical questions. Sidney's professorial appointment is not only well-deserved, it's timely and essential. So to conclude, the WFC Global Patient Safety Initiative is a call to build a safety ethic that transcends geography, income, and tradition. It challenges us to look beyond the clinic to the systems, resources, and cultures that shape what care is possible. So I think as the co-author of this initiative, I strongly and passionately believe the path forward will require curiosity over certainty, humility over hierarchy, and collaboration over competition. If we truly want to keep patients safe, we must meet them and their providers where they are. Thank you all for your attention, and congratulations once again to Professor Rubinstein on this well-earned and important milestone. Well done, Sydney.
Thank you, Richard, for this important plea for international support and collaboration. And I think it's great that the WFC would like to take this responsibility, and especially in current times where governments don't seem to invest anymore in international support and collaboration. So I think that's great. We are at the end of this event. We will hopefully all go to the inaugural lecture of Sydney. That will be in the main hall of the university, and it starts in about an hour, 4:45, 4:45. Be there at least 10-15 minutes before it starts, so around 4:30. And the easiest thing to do to reach the main hall is to go here to the right and to the right again. Then you are in the main hall, and it's one level up. But there are signs to the main hall, the aula in Dutch. So I hope to see you there, and thanks again for the speakers for their great presentations. Thank you.